Alrighty, so this is the last lecture in the predetermined series that I put together for you all for the beginning of the year. So we're going to be talking about pharmacology, and I am specifically going to be focusing on what you're going to use in private practice. You're all dentists. You've had the pharmacology where it's been taught by the angry pharmacist from the pharm school. If you were us, he was British. He was really mean. And I don't know if you guys know this, my wife also went to the same professional school as me, but we were in different cities. And so we didn't know each other then. We actually met online. But when we were talking about the pharm class that I had, and she was like, oh yeah, he was super mean. So doesn't matter. But the point is, you guys all have the background of, I'm not going to be talking about, for example, the blood pressure drugs or stuff that you guys would see on med histories. I'm going to be talking about the medications that you all will use in your day-to-day practice. So with that being said, I'm going to start off. There's been a couple of questions from the last few lectures I wanted to address. So the first one is actually from Leighton. His mom's aunt and uncle are both dentists, and they played my video for their speech study club, which is I try to treat these as me just having a chat with my friends, and I didn't know it was going to be that professional, but I'm not going to change how I am. And the question was, given that you had a AP discrepancy, why would you not do a maxillary mandibular advancement, pull the jaws forward? And that is a very good question. I actually had this conversation with Jeff Rouse in Scottsdale when I was down at Spear and talked about my own case and showed him things, and that was his response is, you got to just do that. The problem is, my teeth are ridiculous. My sinus drops down really, really far. My molars are all 25, 28 millimeters long. My canine's like 35 millimeters long. So in order to go high enough, it would be a borderline Lefort 2. We'd be involving the sinus. It would be just an absolute mess to fix all of that. So in a lot of people, that is what would be the best treatment, is to go ahead and move the jaws forward. In my case, though, I didn't want to deal with all the repercussions of having the surgery. Now, if this doesn't work, I can always go to that. And the good news is we've improved the bone. You can actually see right here, that's how much bone we gained with Nate doing the surgery. So very thick amount of bone here. So even if I do have to go down that road, it's not going to be nearly as far that they have to move. And so ideally the complications should be minimal. The good news is we're making a pretty significant difference as far as the movement. I've already gained quite a few millimeters. And like we talked about, the symptoms are what I'm actually going off of, and those have improved quite considerably. So good news there. And then a couple of anesthesia questions, which is, if you're good with gout gates, why would you even give the IAA? Did you guys so this book just showed up one day on all our desks. I think the AE gave it to us. Do you guys still get this book? This is the second edition that I have on the screen.
We got it this last time we went.
Awesome.
I didn't get sad about it.
It's such a good book. Usually textbooks aren't great. This one is so amazing, because read it. Literally just borrow one of theirs and read through it, because it's great. They literally, opening up a quick page. Combination anesthetic solution of meperidine and lidocaine. Shows a couple references and then says, in conclusion, adding meperidine to lidocaine does not increase pulpal anesthesia in an IAN block. Cool. Done. It is all just that quick. It's all clinical. It's all the questions you want to have. And that's where I learned a ton of this. So cannot recommend this book highly enough. The new one is on Amazon. It's like $70 or $80. I'm considering buying the second edition just to see what's changed. But incredibly useful book. Cannot recommend that highly enough. And one of the things that they showed there, oh, by the way, this is all the Ohio State people who are doing all their Reader New Syndrome. If you ever have any questions on boards about anesthesia, just throw out one of their names because they're bound to be the ones who did the study in the first place. They're not going to ask you any questions on anesthesia on boards. I'll just tell you that right now, because the answers are, you just use Ohio State. Anyway, in this book, it talked about that if you get the IA numb at 2 points along the nerve, it has a higher chance of success than if you get it numb at the same spot twice. Different spots along the nerve have a higher chance of success. That's why I give both the IA and the gout gates. And then the other question was on the deep interdental technique, and I realized I didn't kind of go over this. If you're giving the injections, the question was, do you just give it on the buccal, just on the lingual? I give all four. So if we're having trouble with anesthesia, I'll usually start on the buccal, do 1, 2, move over to the lingual. And then if they feel it on the lingual, I will often then give the mylohyoid as well, because often the mylohyoid will come out and pick that up. You'll often see when you're giving that injection that it's a lot of pressure, and then all of a sudden it becomes really easy to push, and you've kind of pushed through the connective tissue, and you actually tend to drop down, and the anesthetic follows the path down to the mylohyoid. So that's what we do for the mandibular. And then I also wanted to just talk about palatal injections, because that is a painful injection. The way to make it more comfortable is you give 2 interdentals on the buccal first, and you're aiming to have the needle about at the contact point. That pressure, they might feel it slightly, but it's way better than going straight on in with the palatal. Did you guys learn the 6-step nasopalatine injection in dental school? Does that sound familiar to anybody?
No, it doesn't sound
Okay,
familiar.
so the 6-step nasopalatine, let's see if I can remember all 6 steps. You pretty much give 2 local infiltration / IOs right around the laterals. You then go in interdentally on each of the sides like this first, not with the middle. You then go into the middle between 8 and 9, and using a mirror, you slowly advance the needle while pressing until you start to see blanching on the palatal, and then you give the nasopalatine. And I've had this done to me. Actually, Nate did this version of this to me when he did the surgery on me last, and it really doesn't hurt. And that can be this if you go straight into the nasopalatine, that's a ouchie. So it's a way, if you do need to do anything on the palatal, get the buccal numb first, start to use those interdentals to pick up the palatal tissue, and then eventually get the palatal, and it's going to be a lot more pleasant experience for the patient. Any questions about that? Sorry, I didn't cover that last time. All right, back to drugs. Great SNL sketch if you haven't seen that one about E-meth. All right, I kind of differentiate the medications that we use in endo into 3 types. We have those before, those we give during, and those we give after. So for those we give before, it's going to be kind of all the things that you can do to make the patient feel more comfortable. Antibiotics are really common that the general dentist or someone else has given it to them beforehand, so they'll come in already on the antibiotics. They may be taking either ibuprofen or Tylenol for pain management, sometimes Norco, depending on the general dentist. You will sometimes be giving them benzos for relaxation, and then sometimes if they have issues with jaw locking, they'll come in on muscle relaxers as well. During are the ones that we talked about the last 2 times with local anesthetics and nitrous. We'll talk a little bit about when I give steroids. And then post-operatively, we can give them a lot of different things. I'm planning on this being 2 lectures so I can tell more stories. I do like this something else. A few years ago, my buddy and I took our significant others down to Mexico, and we were hanging out in Cabo, and there were these guys who would come along with these cigars, and they'd be like, "Senor, cigars?" And you say no, and as they walk by, under their breath, they look at you and go, "Or something else?" So, I always have, anytime I talk about drugs, in honor of Nick, I do have to throw that in there. We are no longer with both of those significant others, so I cut them out of this picture, but that's Sammy Hagar. We actually ran into him at his bar down in Cabo, so it was a very fun time. Nick and I are still very good friends and talk at least every week. So, if you'll allow me, I'm going to get on a quick soapbox here. By the way, AI has gotten a lot better. I've used it for a lot of the stock images since starting this a few years ago, and this is the first one I was like, that actually looks solid. I told it, give me a male doctor in a white coat standing on a box, and then I wrote soap on it, and it actually looks pretty legit. So if you guys ever need stock photos, AI is not a bad way to do it. I think it's very important that we communicate well. And I think the way in which we communicate says a lot about your education and kind of your just ability to educate. Just say it very poorly as I'm talking about communication. Brand name drugs are capitalized. Generic drugs are all lowercase. So for example, Advil, Tylenol, Norco, all capitalized. Ibuprofen, acetaminophen, hydrocodone, all lowercase. APAP is an acronym for acetaminophen, and acronyms are capitalized. I don't know why this always bothers me, but I've seen many lectures at the AAE, at the ADA, of people talking on pharmacology, and they still somehow mess this up. I don't know why it bothers me, but it always has, and now it will bother you as well. So, you are welcome. Okay, we're also going to go on a slight little psychological detour, because if you know anything about me, I think the psychology of how we talk to patients is incredibly important. So, I'm not sure how many of you saw this study. This came out in 2014, so it's been out for a long time. And really what we're going to be talking about is the placebo effect. So we're all familiar with the placebo effect. But I don't know if you guys know exactly how strong it is. This study found that 50% of the effect was attributable to the placebo effect. And I've seen people talk about it before, how it's it's like, oh, people are so dumb that they just, they'll believe anything. But I look at it as it's a great opportunity because we can use this to make the medications that we give far more effective. Because what they showed is that if you increase the positive information about the medication that you're giving, it helped in both the placebo and the treatment groups. So, and this was looking at migraine attacks. So they've done this with pain management. They've even done this with antibiotics. There is a placebo effect to antibiotics, and if you make people feel that this is the best antibiotic for them, they'll actually get better faster. It's crazy how effective the placebo effect is. Takeaway here is the most important factor in whether or not, as far as how well a medication works, is if the patient thinks that you believe this is the best medication for them. So a way you can phrase this is something like, we're going to give you amoxicillin. It's the best for this sort of infection. Wow, I'm getting the best drug for this sort of infection. This dentist really cares. I'm going to prescribe you a steroid. It's an incredibly powerful anti-inflammatory medication that works specifically for patients like you. Wow, I feel seen and heard, and I get an incredibly powerful medication. I know this seems silly, but if you're serious about it when you deliver it, patients feel so much better. We very, very rarely get post-operative calls, and I think a lot of it is because we tell the patients and give them something to do. We'll talk about that in a little bit. It's very important for people in pain to give them something to do to make it better. Okay, starting off with antibiotics, probably one of the most boring drugs that we give, but a very important drug that we give. So these are all the different antibiotics that I tend to use in clinical practice. There are many, many, many more. These are the ones that tend to actually work for dental drugs or dental bugs and are relatively affordable. As far as loading dose, everyone know what a loading dose is? You give them 2 pills immediately and then just the rest of the prescription after. That's a loading dose. The evidence shows that it does help. And more importantly, we're going back to the placebo effect. For a patient who's swollen and in a lot of pain, imagine how it feels to hear from the dentist, I'm going to give you what's called a loading dose. We're going to get 2 pills in right away. It's going to spike that bloodstream, and it's going to make such a difference for that infection. I'm also going to give you a long-acting anesthetic. So I want you to go straight from here to the pharmacy. Jenny already sent it in, so it'll be ready by the time your appointment's over. And I want you to take those pills in the parking lot. Let's get these things in your system as soon as possible. Or even better, if you have the prescriptions in the office, we have amoxicillin. Hey, I think it's really important that we get this in your system as quickly as possible. We're going to give you 2 pills right now. Makes a huge difference in them feeling that they have the ability to make a difference and that you care enough to give them the special treatment. We all want to feel special. That's the takeaway from all my lectures. Do you guys know how long it takes for antibiotics to take effect?
6 hours.
A few more than that. So it takes about 2 to 3 days for the antibiotics to get up to high enough levels in the bloodstream for it to actually become effective. I'm not going to tell patients that. Imagine how you feel if it's like, all right, we're going to give you an antibiotic for your infection. It's going to take a couple days. It's going to hurt in the meantime. That's called a nocebo effect. So it actually makes things worse. So I generally don't tell patients about this unless they have already been prescribed the medication, come in on it from their general dentist. And if they say, hey, Dr. Smith gave me these antibiotics yesterday, they're not taking effect. So happy that Dr. Smith gave you those, get those in your system. The problem is it does take about 48 to 72 hours to take effect. So what we're going to do, I'm going to have you keep taking those. It's really important you take those as instructed. Which ones did he give you? He gave you amoxicillin. Oh, that's a perfect drug for this. 3 times a day, right? Okay, cool. That's great. Make sure you take those 3 times a day. And then what I do is I don't tell that a lot of people are bad at math. And so I don't say 48. I try to say 48 to 72. So they're not calculating, oh God, that's going to be another 2 days of pain. Give them something to do. You make sure you take it. It's all right, an antibiotic. We're going to drain it today. We're going to whatever you say. And then give them an out. So if they saw Dr. Smith on Monday and it's Tuesday, that means by Wednesday or Thursday, they should start to feel better. So we say the 40 to 72 hours. Tell you what, sometimes these bacteria, this antibiotic covers a lot of them. Sometimes we have to switch to a different one because you have really bad bacteria. And if that's the case, we'll know by Thursday. So if you're still having pain and swelling, I want you to call me first thing Thursday morning. We'll switch you over to another antibiotic, but I want to give this one a chance first because it's usually the best. It's all a psychological game to make them have that placebo effect and make it kick in a lot faster. And the number of times I actually have to switch antibiotics is pretty darn rare. Most of the time, amoxicillin covers enough. All right, let's start off talking about the antibiotics. So on all the medications today, I will be giving the generic name on top and the trade name on the bottom. VTIDS was the trade name, by the way, for penicillin, which is a terrible name. Penicillin has really good coverage. That's why it's still used. The problem is it has to be every 6 hours. The half-life's super quick. It doesn't stick around long enough. And so you need to have the full 2 grams daily. The number of times I've seen dentists write Pen VK 500 TID, it's crazy. It does not work if you do that. All you're doing is make their pee smell funny. Because of that, it has a very low compliance, meaning if they take the medication at 10 p.m., they literally have to set an alarm for 4 a.m. to get up and take it. That's how important it is to actually take the medication like this. So because of that reason, I don't recommend. On all of the drugs, I also include the cost. This is the cost without insurance if you're to buy it off a GoodRx. With insurance, a lot of the generic ones are going to be far, 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 far cheaper. Yeah, maybe like $1 or $2 for most of these. So on that same token, how many of you guys got the little dental drug booklet? Does this look familiar? Yeah. So Peter Jacobson actually is a alumni of UOP. So we get it every year when we go back for alumni meetings. So I have one, my office manager has ones, and he gave us a lecture a few years ago at our alumni event and made a really good point, which is the best medication is the one that the patient's actually going to take. So the compliance rate, if it's 4 times a day, is like 10 to 15%. Only 1 in 10 of your patients are actually taking it as directed. For TID, it goes up to about 40%. For twice a day, it's up around 60%. And for single, just once a day, it's about 70%. So even in the best case scenario, the patient's still only taking it correctly about 70% of the time. So it's important to give the medication in a way that they're going to actually take it. On that same note, we're going to get back on a soapbox and talk about penicillin allergies. How many of you have been told within the last week that your patient has a penicillin allergy, right? I'm sure I'm going to have one today. This came out in 2019. It was in a small little rag called JAMA. They're pretty strict on as far as how they look at things. And what they found is that about 1 in 10 people report being allergic to penicillin. 90% of them don't actually have an allergy. So that means the true incidence is about 1 in 100 of having an actual allergy. And of those, 0.02% actually have an anaphylactic response to penicillin, which is the scary one. Also, I'm sure many of you learned about there's a cross-reactivity between penicillin allergy and cephalosporin allergies. I learned it was around 20% when we were in dental school, so they said that was high enough that if they have a penicillin allergy, it also wipes out the cephalosporins for you to be able to use them. It's only around 2%. So the numbers of people who are actually allergic to penicillin is incredibly small, and of those, the number of them who actually have an allergy to cephalosporins is also incredibly small. Said another way, we should probably be using a lot more amoxicillin. I know you all know this, but I just wanted to review. There's a big difference between a side effect and an allergy. Side effects are normal sequela from taking the medication. Allergies are mediated by immunoglobulins. There's different types, but for an example, if you're taking an opioid and you have nausea, that's a side effect. That's very common. You've probably seen this in a lot of patients who say, oh, I'm allergic to codeine. Well, codeine is a terrible, terrible, terrible drug that makes you feel like shit and doesn't actually do a difference as far as making any pain relief. So that's why they have that. That's not an allergy. That is how the medication works. Whereas an allergy can range from, I get a little rash, to I die. And so it's important to talk to your patients about this. The real question is, whose job is it to educate the patients about this? Because we all know this, but the patients don't. And I don't have a good answer. I don't know if it's the pharmacist, I don't know if it's us, I don't know if it's their physicians, I don't know if it's the government via public information, but this is something that needs to get out there because we're definitely, a lot of patients are getting marked for allergies, and once they are marked for an allergy, it's near impossible to ever get that off any medical history ever. A number of times I've been told, oh, I'm allergic to penicillin, but I can have amoxicillin. And I prescribe amoxicillin, and the pharmacist calls saying, oh, they're allergic, you can't give that. Well, they've had amoxicillin in the past, so clearly we can't. This is something that needs to be addressed, and it's far greater than me and you guys figuring it out. On that same note, there's a concept of antibiotic stewardship, which I am very passionate about, because does anyone know the last time we had a new antibiotic drug class come out? Take a guess.
2014.
2014? It was the year I was born. 1987 was the last time that we had new antibiotics come out, a new class. Now, thankfully, I think it was 2021, There's a couple new classes that are coming out specifically for it's all for MRSA. That's all they're looking at is trying to control MRSA because it's multi-drug resistant at this point. And there's just no incentive for drug companies to invest money in antibiotics because they would much rather invest money in cholesterol drugs and blood pressure because you take it daily for the rest of your life, whereas antibiotics you take short term. So we are running out of antibiotics very quickly. And if you look back to pre-antibiotic times, that's how most people died. And if we don't do anything about it, we could soon be back to an era where antibiotics don't work, and we're going to see a lot more deaths from avoidable infections. So we're in a great time right now because antibiotics are here, but that's not a guarantee. Because of this, they should be only prescribed when needed, which means all the general dentists giving it for sip-sap have to stop. It's not useful in those cases. That has been shown time and time and time and time again. When we give it, it should also be the right drug, the right dose, and the right duration. Example there, PenVK TID. All you're doing is giving a subclinical dose of penicillin to the point that you're going to make more bacteria resistant to it. If you only give it for 2 days instead of the 7 as recommended, that's not enough to kill all of them. You're going to make more drugs resistant. And when you give it, you want to avoid broad spectrum. This is way more physician colleagues who love giving these crazy broad spectrum drugs. But for us, amoxicillin is perfect because it really hits just the ones in the mouth and doesn't really hit anything else. Very rarely will I hear that there's diarrhea with amoxicillin. Clinda we'll definitely talk about in a little bit there. Make sure you know the correct dosing as well. And it is okay to correct it. On the patients who came in with penicillin and the wrong dose, usually switch them over. I'll say, okay, we're going to do amoxicillin TID instead. Don't let them keep on the wrong medication. Correct it. You guys all know the dosing. I will make this presentation available to you all. It'll be on YouTube. I can write it out, but this is really important. Okay, the AE has a bunch of different position statements, and many of them are very useful. This is one of them. The cone beam one is not. And they have a really good thing talking about when you should actually use systemic antibiotics. Really, it's swelling, regardless of if you do the incision and drainage. If you start to have symptomatic symptoms, the apical literature is half and half. So I do it right now because it does seem to help with flare-ups after. Is it absolutely necessary? Probably not. They'd probably be okay. But that's really about it. They have to have swelling. They have to have really bad, fevers. They have to look terrible, sometimes with surgeries, especially if they go long. And then the other time is when the day before vacation. I guarantee every pharmacist right now is getting so many more prescriptions for painkillers and antibiotics because Christmas is coming up. All right, I think I have one more rant, but it's later on. So let's go through the rest of the antibiotics here. Amoxicillin. I do like this. This is actually a decent brand name, Amoxil. Okay, that's solid. It does have a slightly wider coverage than PenVK. The beautiful thing is you can give it twice a day. So this is actually my prescription. I give 2 tabs stat and then 1 Q12H until gone, 7 days. Works extremely well. The 875 has a very high compliance rate, very low side effects. It's wonderful. I will still give the Q8H I'll talk about that in a second, but most importantly, it has the good compliance, and we want to give patients drugs that they'll actually take. It's also very affordable. All right, let's talk about Clinda, or Cleocin. Also, another good trade name. It has great coverage. It has too good of coverage, which is why we've had some difficulties with it. It comes in 2 strengths. You can either get 150 or you can get 300. There's been a lot of literature showing there is no difference in C. diff between 150 and 300. So if you're giving it, it's usually going to be in the really nasty infections, as I'll talk about. Give the 300. If a patient is very financially motivated, it is cheaper to give double the amounts of 150s than it is the single 300s, but you have to trust that the patient is actually going to follow those instructions. You can give it either Q6H or Q8H. As we talked about though, compliance is pretty low for Q6H, so I tend to do Q8. And in 2022, the FDA no longer recommends it for routine use. You don't use it for prophylaxis anymore. You shouldn't use it as a primary antibiotic because of C. difficile and having the nasty, nasty, nasty side effects thereof. It's pretty affordable, all things considered, and there is still a use for it, and I'll talk about that when I go through kind of my flowchart for which ones I'll do. All right, because of clindamycin getting pulled, or not pulled, but lessened, we're seeing a lot more prescriptions for Z-Paks or azithromycin. Great trade name, by the way. The benefit here is that it's extremely easy to take. This is if you've never taken a Z-Pak, this is what it looks like. They tell you exactly how to do it. What do you know? They give a loading dose, and then it's once a day. That's why everybody loves Z-Paks. The problem is the coverage is kind of meh. It's not that great for dental bugs. If the infection's kind of mild and I just want to make sure that they're not going to have really bad flare-ups, I'll usually use a Z-Pak, but I don't give out a lot of these because there's other drugs that I think work a lot better, and it's usually going to be your first choice for a penicillin allergy. So you're going to be seeing a lot more patients come in on azithromycin, and you're probably going to be seeing a lot more of it not working, just because it doesn't have great coverage of the dental bugs. Moving on to Augmentin, which is amoxicillin, and then they add in something called potassium clavulate. It does have better coverage than amoxicillin because it works on penicillinase-resistant bacteria. So this is penicillin. It has a lactam ring right here, that little square with the nitrogen. There are bacteria that developed a enzyme called penicillinase that can come in and split this. This ring is what gives all of the cillins their effectiveness, and so if this is split, it no longer works. So in the classic battle between antibiotics and bacteria and researchers, they now have potassium clavulate, which then goes in and stops the penicillinase from working so that it can still work on those bacteria. It comes in two different strengths. You can either do TAD or BID, just like amoxicillin as we talked about. It is a little more expensive, and I will use this in certain situations. Once again, we'll go to the flowchart at the end. Metronidazole, like I told you guys, I did a lot of research in undergrad, and we worked on specifically Trichomonas vaginalis, which is this little dude right here, and that is the usual and only indication for flagell. It is only in females. You can figure out where it comes from based on the latining, and it works really well in those cases. It only covers anaerobes, and it works, once again, great trade name. It's called flagell because these have flagellum. So these are little swimmers. And the metronidazole knocks that down. That's my research, was trying to figure out how exactly it worked. And it's very useful in the really bad swelling cases because you're going to have a lot more anaerobes there. The dosing is 500 milligrams TID. Because of that, you have to give it with something that covers aerobic bacteria. Generally, that's going to be either amoxicillin or Augmentin. When I told you there were times I would use the 3 times a day, it's right here because they're much more likely to take both pills 3 times a day. Then remember, okay, I got to do the one once in the morning, once at night, but I got to do this other one halfway through. And when do we? It's easier if you just make it easy for your patients. The other thing is I only give these on the really bad swelling ones. Those are the patients who are going to listen to you because they want to get that swelling to go down no matter what. So the amount of pain that a patient's in is often going to help you figure out how compliant they're going to be with the medication. The one thing about flagell is that they cannot have any ethanol in their body. It gives them an instant hangover. It's called the anti-abuse effect, and this includes mouthwashes. If they're used to using like Listerine with alcohol in it, that alone can actually give them a hangover. So it's very important that you caution them. If you have any ethanol, including from mouthwashes, you can get an instant hangover with this. So no drinking while on this. They'll figure it out real fast. Shout out to my lab at UOP undergrad. All right, one of the ones we are starting to use a little bit more of now is called cefdinir or Omnicef. This is a cephalosporin antibiotic. This is what we're using because it has much better coverage than azithromycin. It is TID, that is one of the downsides with it, but it does work in those penicillin allergic patients. It's also a little bit more expensive. So unfortunately, when we lost Clinda, we had to come up with some other things. And so this is my backup for those in between where they're allergic. As far as the strategies, first thing I'm going to use on everybody is amoxicillin 875. All these are with loading doses, by the way, and I try to do the twice a day just for compliance. If after 2 to 3 days they don't have any response to that, we're going to switch over to Augmentin and metronidazole. Both of these will be 500 milligrams 3 times a day. If they are allergic, depending on the extent of the infection, we'll either use azithromycin or cefdinir. And then if they have a really bad swelling, or if the other medications have been failing, that's when I'm going to start to use clindamycin. Clinda has a better ability to penetrate than the other antibiotics, and so it still has a use in my practice. I primarily give it to people who are already in the medical field and know what to look for, and you tell them, if you have diarrhea, stop taking this immediately and call me. Thankfully, I've, knock on wood, have not had anybody have these issues, but it is still a useful drug. If they still have issues after this, that's when they need IV antibiotics. They usually give them Clinda, so I do know it is still a useful drug. But sometimes you do have to get them IV. And if they either have difficulty breathing from facial space infections, or if you're still not getting any response and they're having really big issues, oftentimes they got to go to the emergency room and get the IV. Any questions about antibiotics? Like I said, I know they're not the most sexy of drugs that we give, but they are an important one. And hopefully that flowchart helps you guys kind of pick and choose which ones to give. Moving on to over-the-counter painkillers, NSAIDs and acetaminophen. You've all seen this before. This kind of talks about the cyclooxygenase pathway. When you have damage to the membrane, the lipids are released. Phospholipase A then comes through, creates arachidonic acid. It then goes through two different enzymes, depending on which one is present, lipoxygenase, which creates a bunch of different things that ends up creating leukotrienes, and then it also goes through cyclooxygenase, or COX, which ends up creating prostaglandins. And those are the main ones that we're trying to hit. When we work on the NSAIDs, primarily work on COX-1 and COX-2. And there's a lot of very interesting stuff if you haven't read on it about Vioxx and the scandals and COX-1 versus COX-2, because some of these things, it's a very long story. Definitely worth looking into, way outside the scope of this. But let's go ahead and talk about NSAIDs by talking about one that's not an NSAID, which is acetaminophen. It comes in two different strengths. You have 325 and 500. I do the 500, 2 tabs every 6 hours. Your maximum dose is 4 grams. Now, if you look online, they have lowered that. We'll talk about why in just a second. Mechanism of action is still kind of we were told it was unknown. They thought there might be a COX-3. The most recent evidence has shown that acetaminophen works by inhibiting the synthesis in the central nervous system, whereas ibuprofen is going to work peripherally. So that's why you can take these at the same time, is because they work in different areas. So you're not going to have additive effects. You're going to have good additive effects. You're not going to have more side effects by taking both of these at the same time. The big thing here is acetaminophen works through the liver. And this can cause damage. We'll talk about that. The beautiful part is Tylenol is incredibly, incredibly, incredibly cheap. These are per pill costs. Literally less than a penny per Tylenol. So very, very cheap. What happens is when acetaminophen comes into the system, it immediately goes through a process in the liver using P450, which is what everything goes through, and it creates something called NAPQI. This is a toxic, super, super, super toxic chemical to the liver. The most horrible way to die is to overdose on acetaminophen, because it's liver failure and the only thing you can do is get a new liver. It's absolutely terrible. So you have to talk to patients about this. Ethanol also works through this, and so you have to be careful on people who like to drink a lot. Acetaminophen's not a good drug, because what happens is the liver is very used to metabolizing ethanol, and so it'll prioritize all the ethanol before it goes on to the NAPQI, which can lead to toxic buildups inside there. And then eventually it goes through more processes and eventually it turns into something that's not toxic. So this is why we worry about acetaminophen, is because it can be toxic to the liver, and it's very easy to overdose because it's in a lot of things. And once again, ethanol makes this worse. This is just a small list of the drugs that have acetaminophen in them. You'll notice a lot of these, and things that you wouldn't necessarily... Why does Dayquil have acetaminophen in it? Why does NyQuil have acetaminophen in it? Why does some Midol? Like, it's in so many different things. So that's why they lowered the maximum dose from 4,000 to 3,200, is because it was in so many different things. However, the maximum dose, like physiologically, they can have 4 grams. They just lowered it because a lot of people were taking it in other things and not realizing how many things it's in. They just shoved Tylenol in everything, as you can see. And that's why this information comes from the Liver Foundation, is because a lot of people lose their livers and lose their lives from overdosing on acetaminophen. Moving on, good old ibuprofen. There are 2 different formulations. You have over-the-counter, and for some reason the 6-800s are prescription. I don't know why. There's technically from what I was told by a pharmacist, the 600 and 800 can technically work a little bit faster because the ibuprofen is located inside the capsule. And so because you have to dissolve 4 of them versus just 1 pill, the 800 might work a little bit faster. That's why they exist. I don't know why they exist, because it's incredibly cheap just to get this 1,000 at Costco cost a penny per. It's super cheap. It is non-selective, meaning it gets both COX-1 and COX-2. You guys all remember that from taking your pharmacy pharmacology classes, the dose that we give for maximum anti-inflammatory effect is going to be between 600 and 800. Your maximum dose through the day is 3,200. Both of these drugs have what's called a ceiling effect, meaning that taking more doesn't make anything better. And so a lot of our patients will come in and say, oh, I'm popping 9 ibuprofen at a time. That's not, you're not making yourself feel better, you're just killing your kidney. And on that same note, if they have bleeding issues because of hitting both COX inhibitors, it can cause more bleeding, especially in the GI, and it does work through the kidney. So patients who are on dialysis, if they've had a kidney transplant, things like that, they can't take ibuprofen because of the effects on the kidney. Okay, combo drugs are really cool. The way that we tell our patients is, take ibuprofen, take Tylenol, back and forth. That's what pretty much everybody says it. In 2020, the ADA worked with the FDA on getting these combination drugs approved. Unfortunately, they kind of suck because it's only 250 of acetaminophen and 125 of ibuprofen, which just doesn't make sense. You have to take 2 tabs. It's 3 times a day. So you're getting 1 extra strength Tylenol and a pill and a half of ibuprofen 3 times a day. It's also a lot more expensive. Or you could just be smart enough to take 2 pills at the same time and get them for literally 2 pennies. So don't love that one. There are ways to make ibuprofen kick in faster. So liquid ibuprofen kicks in about 15 minutes faster. It is more expensive. However, there have been a lot of studies as far as anesthesia showing that if you have ibuprofen on board beforehand, it does make a difference as far as effectiveness. So if you have a little extra time, patient comes in, they're in a lot of pain, start them on ibuprofen. And if you want to get them going real fast, you can use the liquid version. If you want even faster, there is this wonderful drug called ibuprofen sodium dihydrate. Works super, super fast. And this idea, I actually heard about this from, I think it was Hargraves, talked on the AE thing way back when, about using it to increase nerve block success. The problem is, it's not here, and I have no idea why. It's available in Australia, but it's not available here. If anyone knows why, please let me know. But for some reason, we cannot get this drug here, and it would be a wonderful drug because it kicks in super, super fast. So you could use it for people who are having issues with anesthesia. So as far as combining them, works extremely well. 1 ibuprofen, 1 extra strength acetaminophen gave 60+% patients over 50% pain relief. 15 milligrams of oxycodone gave 20%. That shows you just how effective these are. The big difference, and I don't think we'll have time to get through opioids today, ibuprofen and acetaminophen get rid of the pain. Opioids make you not care about the pain. That's why people like opioids, is because it makes them not care. We'll talk about that, but we'll finish up here with naproxen. The nice thing about it is once or twice a day. And so a lot of patients really like this because it gives them, okay, we take it in the morning, we take it in the afternoon, kind of talking about, antibiotics, things like that. But there is something to be said about giving the patient control of their pain. By just doing it twice a day, if they take it at 8 and all of a sudden they start having pain, they can't take another one until 8 p.m. What we do instead is tend to, on the patients who have really, really bad pain, we'll have them start with ibuprofen, 3 hours later take Tylenol, 3 hours later take the ibuprofen. And what happens is they tend to peak when the other starts to fall off, and it gives them a much better pain relief throughout the day, and it gives them something to do. Instead of thinking, oh, I have 12 hours until I can have pain relief again, they're thinking, okay, it's 10 o'clock. At 1 p.m., I can take another pill and I'm going to be feeling better. And then I can take another one at 4. And so it gives them something to do to help with their pain, which makes a huge difference. I'm going to finalize with this. This is the Oxford League table of analgesic efficacy. That's why some of the spellings are funny, because it's British. And what you'll notice is ibuprofen 800 gave 100% of patients at least 50% pain relief. And the number needed to treat to see an effectiveness was just over 1. This is incredibly good. Just to show you some of these other ones, we'll highlight them there. Notice that this is 2 Tylenol 3s. That was at 57%. Oxycodone with 500 of Tylenol is 60%. Nothing touches ibuprofen. It's ridiculous. Immediate relief oxy is all the way down here at 2.3 needed to treat, which tells you a lot of the pain relief people are getting from these combination opioid drugs is actually from the Tylenol, or ibuprofen in the case of ibuprofen, rather than the actual opioid itself. And we see this all the time. Even down here, ibuprofen 200 is better than tramadol. by quite a significant margin. We see doctors giving out tramadol left and right, but for some reason, they're afraid of ibuprofen. I get it in elderly with bleeding, but on the patients that we see on an everyday basis, it's a fantastic drug. We should use it all the time. Let's go ahead and stop. We'll finish out with a couple more questions. All right, guys. Was that useful to kind of, I know you guys have used these drugs. You know a lot about them, but hopefully this gives you more of like a day-to-day clinical basis. The psychology stuff is really, really, really important. I know I harp on that a lot, but it really does make a difference on these patients to make them feel seen and heard. And that's all you usually have to do. I'm knock on wood, because I'm probably gonna get 1,000 post-op calls now that I said that. But we don't really get a lot of post-op ER calls because we handle it in the office. And that's what you want to do as well. All right, what questions do you have?
Do you have a lot of patients that complain about their general dentist not giving them antibiotics, and then you kind of have to talk them through like this antibiotic stewardship?
It's a good question. Thinking how to answer this delicately. Since starting my own practice and kind of curating the dentists that I work with, no, because I tend to work with fantastic general dentists. When I've worked in different areas where, trying to figure out the phrasing here. You guys know what I'm talking about. If the quality of the, one thing I will say is that the quality of the patient follows the quality of the general dentist, and so the better general dentists tend to have better patients. And so if I get referrals from offices that tend to not have as good a reputation, their patients don't either. And so I see it more in those cases. Defend the dentist, explain why it's not necessary. I usually talk about, we don't want to destroy your GI system. You don't want to have diarrhea. It can cause issues. We're trying to, as we're learning more and more, realizing that antibiotics can have long-term effects if we give them long-term. Like, there's different ways and just kind of tailor it to the patient. But to answer your question, no, not as much anymore because I work with some fantastic dentists. But in the past, I did have more of those. Anybody else? Yeah. Go ahead.
No, I think that was a good question too, because I feel like we definitely get a lot of angry patients that are like, why didn't my dentist give me this? The tramadol thing did make me laugh because I feel like I know I've heard people giving that.
Right.
Sometimes like the placebo of just it not being aspirin, ibuprofen, or Tylenol. They're like, ooh, they're giving me the good stuff now. That like just the name change off is placebo effect to get them being like, oh, they're giving me the good drugs.
and you guys probably got a little less than I did, but we were in the thick of the opioid crisis when I was in dental school. And we would, every extraction, every endo, every visit would get a minimum of 12 Norco, period. When I started working at the endodontist office here, every appointment he'd write a script for 12 Norco, period. You can see that's definitely changed. I give out narcotics maybe 4 times a year, maybe. We're not giving it out. And I think a lot of patients are starting to understand that. We went from a phase where everybody expected it and they would get pissed off at you if you didn't give them an opioid, to where now if I think they actually need one because they're in that bad a shape, they're like, oh no, I can't have that stuff. I'm going to get addicted. Like, I've definitely heard that when I've wrote prescriptions before. So I think we're going, as people get more educated, because the most general people don't understand pharmacology. Why the hell would they? That doesn't really affect them until it does with something like the opioid crisis or with antibiotics coming along and kind of how we use them changing. It used to be like, God, I remember when I was a kid, you'd go to the pediatrician for anything and you'd walk out of there with a prescription for antibiotics. And now you really don't see that anymore, and we're in the same way. So it's a good skill to learn, because practice it now on the patients you guys are seeing. Know that when you get out, based on the patient demographics, you're probably going to have less of those conversations, but you'll have the skills to handle it now. Great question. Any other questions? Cool. All right. We'll cover all the fun stuff next time. All right. Have a good one, guys. Have a good Christmas. I'll talk to you guys in January. Yep. Okay.
Merry Christmas.
Yeah, Merry Christmas. Bye.